Well, welcome to Samaritan's Purse International Health Forum. Thank you for joining us today. We hope that you participate in our conversation today. Just want to remind you that you can chat with us in the chat box beside the video. We're excited to hear from Dr. Andrew Huang this morning on the case for global surgery. Before we begin, let's just start with prayer. Father God, we thank you for today. We thank you for the opportunity to learn and grow in our specialties. Lord, we pray that you would speak to us through Dr. Andrew's presentation, Lord, and Lord, that you would just help all the technology to work correctly, and that you would just go before us today. Thank you for this opportunity to learn and to serve you across the globe. In your name we pray, amen. Just a little introduction on Dr. Andrew Huang. He attended Jefferson Medical College in Philadelphia, and he completed his residency in plastic surgery at the University of California, Davis in Sacramento, and he did a craniofacial fellowship at St. Louis Children's Hospital. He is a diplomat of the American Board of Plastic Surgery and a fellow of the Royal College of Surgeons of Canada. Dr. Huang has participated in multiple short-term mission trips and has trained and operated on 6 continents. He also served 1 year with World Medical Mission at Kapswar Hospital in Kenya. So without further ado, Dr. Huang, if you would begin your presentation.
Well, thanks so much, Beth. It's a true honor and pleasure to be invited to the International Health Forum here at Samaritan's Purse. So today, the topic that I decided to present on is the case for global surgery. That is becoming increasingly a topic of interest for surgeons as myself. As you mentioned, I'm a plastic surgeon. So some of the stuff we're going to be talking about is not exactly plastic surgery, but we'll get to it, and hopefully everybody tuning in later will find it interesting. So let's go to the first slide here, or the next slide. I have no financial disclosures, but on the next slide you will see that I have several other disclosures I do want to mention. About some public health stuff. I am not a public health officer or an epidemiologist. I am very much a craniofacial trained plastic surgeon, which means that I'm very much focused usually on one at a time, and at that really just a small area of that patient at a time typically. I'm not the sort of person who's used to having a bird's eye view of the entire picture of global health or the global burden of disease. So I'm sure there are people that are listening today or later on who are more well-versed in a lot of this stuff. If you are listening live, feel free to participate in the discussion. You can use the chat box and add your comments or questions in there. So we are going to be talking about some of this stuff, just to let you know it's not firmly in my area of expertise, but it is stuff that I'm very interested in as somebody who's been on multiple medical mission trips before. So next slide. Let's start off real quickly with a definition of global health. This is from the National Library of Medicine in 2015. And actually, they just redefined it in 2015 after having this previous definition of world health now defined into global health as one of their medical subject headings. And if you guys are familiar with mesh terms, or you guys do literature familiar with mesh headings, global health is a term that's really come up in the literature a lot over the last 10 years or so. So now the National Library of Medicine has finally put that officially as one of their headings. And as we look at the next slide here, we can actually see their definition of global health. Transcends national boundaries, promotes cooperation, and combines both disease prevention and individual patient care. So that's sort of a hodgepodge of all sorts of stuff that goes into their definition of global health. So next slide here. So in this presentation, I'm going to use those terms fairly interchangeably. There's another term out there that you may hear about, international health. I'm also actually going to use that pretty interchangeably. There are subtle differences, and people sometimes have arguments about what constitutes international versus global health versus public health. For the most part, in this presentation, we're going to talk about all three of them as if they're basically the same thing. And specifically, we'll talk about them as it relates mostly to missionary medicine, or the sort of medicine that World Med has really become a big part of, which is serving the poor. So doing real medicine among the destitute and the poor of the world. So that's kind of our focus here today. So next slide. So here are the goals of today's presentation. We'll start off by talking about some of the traditional challenges to surgery and public health and how those two realms of medicine are typically thought as being very different. And then we'll move on and talk about some of the history and the advocacy of surgery within this movement of global health around the world. From there, we're going to take a short detour into some of the public health measures of disease burden, the global burden of disease, and how we do cost-effective analyses in those situations. And the reason we have to sort of make this small detour into the public health mathematics is because that's really where the crux of the argument falls. So our very final point, we'll make that case for global surgery, and we're going to bring in that information we're bringing in from public health burden, global burden of disease, to make that final case that global surgery is a real thing. We should be paying attention to it. If you think about global surgery, you may be thinking about short-term surgical mission trips. And of short-term surgical mission trips, there are really two specialties that have done a lot historically over the past 3 decades or so. Plastic surgery, which is my own specialty, and ophthalmology. So in plastic surgery, you may have heard of teams like Operation Smile or Smile Train. There's actually listed in my society 160 organizations that do for plastic surgery, whether it be most commonly clefts, but also burns and hands. On the ophthalmology side, you've got things like the Himalayan Cataract Project or the Orbis Flying Eye Hospital, again, very famous in their worlds for performing cataract surgery around the world. These are relatively simple operations that can affect quite a number of lives. So that's sort of been a lot of the history of surgical mission trips so far. Next slide. But traditionally, when we think of public health, and when you think of public health, you probably think of infectious diseases, things like AIDS or tuberculosis or malaria. These are sort of the big comes to mind when we think of public health or of global health or the global burden of disease, especially in the developing world. So as we go to the next slide, actually, just last month here in my country of Canada, in Montreal, Justin Trudeau opened the conference for the aptly named Global Fund to Fight AIDS, tuberculosis, and malaria. And at that conference, nearly $13 billion are raised specifically to fight these 3 infectious diseases that are ravaging much of the developing world. So let's go ahead and at the next slide. If you're familiar with global health or public health, you may be familiar with the Institute for Health Metrics and Evaluation. If you're not, I suggest it as a great resource. They provide these great visual comparisons of global burden of disease, among other things, supported up there in Seattle by UW and the Gates Foundation. So we're going to look at a few of these things. So we'll look at the first slide here. And this is their visual comparison of deaths in the developed world. These are all ages and all genders, but only in the developed world. And blue here represents non-communicable diseases. So as you can see, in the developed world, the vast majority of the mortality comes from non-communicable diseases. We have ischemic heart disease, stroke, lung cancer, diabetes, Alzheimer's. Those are big players for causes of mortality in the developed world. The red that you can see fairly small, that is communicable diseases. Smaller part in the role of mortality in the developed world. On to the next slide. This is deaths for all ages, all genders in the developing world. And as you can see, even though non-communicable diseases still cause the majority of mortality in the developing world, we now have a much larger section devoted to the red, to the communicable diseases causing deaths in the developing world. And in the right central portion of this figure, you can see HIV, TB, and malaria. They play a huge role in mortality. So HIV, TB, and malaria are a big cause of death, and more importantly, they disproportionately affect those who are poor. They disproportionately affect people in the developing world as compared to the developed world. And on our final slide here, the next slide, we'll see this is deaths in the developing world for both genders, but for children under the age of 5. And obviously, for kids under the age of 5, communicable diseases are the leading cause of death. You've got pneumonia, diarrhea, sepsis, malaria. These are what kill small children in the developing world. So by no means do I want to underplay the cause of morbidity and mortality in the developing world as being something other than communicable diseases, because communicable diseases is still a major issue in that world. So when we think about public health and surgery, we don't typically think of those two things as mixing very well. And a lot of it has to do with just personnel. When we think about public health, we think about one person being able to do a lot of interventions for many people. So things like immunizations or things like handing out malaria medications or TB medications, right? You can have one person doling out a lot of medications and affecting a lot of people. In surgery, really, we have the opposite scenario, and that's why we don't typically think of it as a public health endeavor. You need at least two, usually three people working on one single patient at a time, if not more, just to treat that one patient, right? So you have sort of this opposite ratio of personnel in surgery as opposed to what we traditionally think of in public health. Next slide. And surgery is expensive, right? We all think of, no matter where you are in the world, as surgery as being an expensive endeavor. Just think about all the things that we need. We need a place to operate. We need an operating theater of some sort. We need, at the very least, drapes, gowns, and gloves. You need stuff. You need both stuff that lasts, durable equipment, and you also need consumables. You need anesthesia. Even if you're working out in the bush, you still need to be able to give ketamine, or if you're only giving spinals, you still need a fresh source of IV cannulas or needles, and you need the medication to deliver that anesthesia. And finally, you have to have some way to reliably wash, rinse, and ultimately sterilize or autoclave all your surgical instruments. So for surgery, there's just a lot of stuff that comes along with that. That again, when we think of public health, typically we're not thinking about all this extra baggage that does come with surgery. Next slide. So again, mortality from infectious diseases is a significant part of the global health picture, and in no way do I want to undermine that by giving this presentation. I have no delusions that surgery is going to fix everything. But I do want to ask this question: how does surgery fit into the bigger picture of global health, especially the way we've been viewing global health in the last 10 to 15 years, and this global burden of disease, which is really this phrase that helps us sort of capture everything that's going on in the world? How can surgery help alleviate that global burden of disease? So next slide. So here we're going to talk a little bit about the history of global surgery and advocacy, and to do that we're going to go all the way back to 1980, and this is really where it starts. Dr. Mahler, he's a Danish physician. At the time, he's the director of the World Health Organization. In 1980, he gives a speech, and in that speech, he talks about the essential drugs. And back then, there were obviously tens of thousands of drugs available, and the WHO had recently come up with a list of about 200 essential drugs that they put up, and they said, hey, if you are running a clinic or a hospital anywhere in the world, and you want to be able to treat the majority of the disease that comes through your doors, if you have these 200 drugs available, you're going to be able to do that. You don't need tens of thousands of drugs in your formulary or in your pharmacy. These 200 drugs are going to cover the majority of the medical burden of disease that walks through your door. So the WHO picked out these 200 drugs. They were widely available and very cheap. Dr. Mahler, at a speech to the World Congress of the International College of Surgeons in Mexico City, made a speech talking about surgery in the same perspective. And he asked, can we do the same thing in surgery? That is, can we come up with a list of essential surgery operations that, if people are trained to do, would be able to treat the majority of the surgical burden of disease that walks through any door in any hospital anywhere in the world? Is that something that we can do? Dr. Mahler was really the first person to link surgery into its role in part of primary healthcare. And for those of you who remember this or are familiar with it, this was just 2 years after the Alma Ata Declaration in 1978. So primary healthcare was on everybody's tongues at the time. This was a really big deal in the international public health world. And Dr. Mahler is really the guy that sort of says, hey, surgery needs to be a little bit part of this primary healthcare model. So next slide. So nothing really happens after that speech for quite some time. In 2005, the WHO establishes the Global Initiative for Emergency and Essential Surgical Care. The idea was to promote collaboration between different entities around the world to improve surgical healthcare in low and middle income countries. To be thoroughly honest, the initiative is understaffed and underfunded, so even though it exists, not a lot happens with it for the next several years. Next slide. Then we come to the Lancet Commission, and this is really the breakwater moment for global surgery. So in 2013, a number of prominent surgeons around the world approached the journal Lancet saying, we are concerned that surgery is being left out of the picture and out of the story of global health worldwide. We want to know how surgery can fit into this. So the Lancet the Lancet came up with the Lancet Commission for Global Surgery, and as you can read there, sort of the purpose of the commission to assemble the best evidence for the state of surgery worldwide and to develop strategies for improving access. This involved dozens of surgery leaders around the world, multiple meetings around the world to come up with a very large report and multiple supporting reports. So their final report came out in April of 2015, just last year, and it's called Global Surgery 2030. It's a very long document, and it's free to download off the internet if you're so inclined. It was accompanied by over 100 supporting academic papers and 7 other journals. So this was really a tour de force that the Lancet Commission came up with to talk about the current state of global surgery. On the next slide, we can see some of the things they came up with. So they said that 5 billion people lack access to safe and affordable care. So safe, obviously just meaning safe, you can go through the surgery and live, but affordable meaning it won't bankrupt you completely. 2 billion people, of those 5 billion people, 2 billion people lack access to even basic surgical care. So we're talking about very simple things here, pulling out teeth or draining abscesses. So even the very basic things, a couple billion people don't have access to that. The commission calculated that 143 million surgical procedures worldwide every year were needed to prevent disability and save lives from these surgical diseases. And they estimated that would cost all countries combined to improve their healthcare systems to safely deliver the surgical care about $420 billion. Again, these are global numbers, so we're talking about very big numbers that are kind of hard to wrap our minds around. But they also came up with the cost of untreated surgical conditions, and they stated that up to 2% of GDP growth is lost, or in dollar amounts, $12.3 trillion are lost because people do not have access to safe and affordable surgical and anesthetic care. So we're talking about something that costs the world over a magnitude of difference than it would cost just to provide that surgical care. So in 2015 and 2016, the 3rd edition of Disease Control Priorities was published, and these are published by, this is actually published by the World Bank, and it's made by the same people that came up with the nice graphics that we saw earlier, so the Institute for Health Metrics and the University of Washington Department of Global Health. This is a 9-volume set for the 3rd edition. And volume 1, for the first time, actually deals completely and only with essential surgery. So these numbers are very up to date. These are the latest numbers we have for global health and for global surgery in particular. And in volume 1, they state that in low and middle income countries, as defined by the World Bank, 6.5% of all deaths can be averted with essential surgery. So that translates to 1.5 million deaths per year. That is most likely a very conservative underestimate. Certain studies have placed this number as high as 25% of deaths that would be averted with access to essential surgery. But a very conservative estimate here, again, we're looking at 6.5% of all deaths averted if people had access to essential surgery. So again, we're not talking about fixing half the world's global burden of disease by having access to surgery, but we are talking about many millions of deaths worldwide every year. What is essential surgery? Let's look at that here. So this is what volume 1 defined as being some of the essential surgeries for a first-level hospital. A first-level hospital is what we think of as a county hospital or a district hospital or just a basic community hospital with 100 to 200 beds. And as you can see here, the list is fairly extensive, but it's all relatively simple things that basic surgeons could get through, whether we're talking about cesareans or hernia repairs, or a chest tube or amputations. The vast majority of surgical disease, as defined by DCP 3rd edition, should be and can be treated at the first-level hospital. There are a few things that can be treated at lower-level institutions, so like health clinics or health outposts. That would be normal vaginal deliveries, simple dental extractions, or simple INDs of abscesses. There are a few operations that are defined as essential that are not performed at the first-level hospital, but at referral hospitals. So things like clubfoot, cleft lip, cataract, and trachoma operations are all referred to the referral hospital. but the majority of surgical burden of disease should be able to be treated at the first level or the district or community hospital if you're able to perform these sorts of things. Next slide. So going back to sort of the history, in May 2015, soon after the Global Surgery 2030 report was published, the G4 Alliance was founded. This stands for the Global Alliance for Surgical, Obstetric, Trauma, and Anesthetic Care. This is over 60 organizations, all different types of organizations. If you're familiar with the Pan-African Academy of Surgeons, they were one of the members of the G4 Alliance, as is Mercy Ships and dozens of others, both academic and NGO. And you can sort of read their purpose statement right there on that last bullet point, providing a collective voice for support of increased access to safe surgical care. The next slide. So in May 2015, same month, the World Health Assembly, this is the sort of the Congress or the decision-making body for the World Health Organization, met in Geneva, and they passed Resolution 6815. And this is really the first resolution that the World Health Assembly has ever passed that deals directly with emergency and surgical care. And so the title of the resolution really gives it all away, strengthening emergency and essential surgical care as a component of universal health coverage. So this resolution was really another moment in sort of global surgery and bringing it to the forefront of the stage in global health. A follow-up report on this resolution is due next year. Next slide. And finally, I'll just mention this very briefly because a lot of people are mentioning it. The Sustainable Development Goals that the UN has set up, the third one, good health and well-being, is the one that deals with health. And some of the targets that they have mentioned within SDG 3 do involve non-communicable diseases. Specifically mentioned are injuries from road traffic accidents and the maternal mortality ratio. So it is a little bit of a mention there in SDG 3 for non-communicable diseases. Okay, let's go on to the next slide. We see here now that surgery, I hope you've seen that surgery is playing an increasing part on the world stage of global health, and really since 2013 to the current time, there's been a lot of effort with the Lancet Commission and the G4 Alliance of bringing this on the world stage and into people's minds. But we really have to ask ourselves, how do we justify the cost-benefit ratio, right? Because when we think about public surgery again versus public health, versus surgery, being very expensive. And we still have to sort of deal with that. How can we say that surgery should be an important part of public health when everything costs so much money, from the personnel ratio to all the equipment? So to make this case and to really get into the crux of the argument, we're going to have to get into some of the math of public health. And so here's where we're going to take that little detour into that math. Again, this is not my particular area of expertise, but this is something that I find really interesting and that we can discuss. So there's three things that we know, right? The first one is that surgery saves lives. And I realize I am talking to the audience at Samaritans person, and really only Jesus saves lives. So I'm using the vernacular here. Jesus does save lives. We only prolong lives, but for the purposes of this presentation, you understand what I'm talking about. Surgery decreases mortality, right? It allows us to occupy our earthly bodies a little bit longer. Whether you're doing a cesarean or a laparotomy or repairing typhoid perforation, you are prolonging that person's life. They otherwise would have died at that point. So that's one thing that surgery does. The second thing that we know is that surgery improves lives. And this is actually probably what most of surgery does, right? Most of surgery is not life-saving interventions. They are dramatic and we enjoy doing them. But the vast majority of surgery that occurs around the world is not to save a life, but to improve a life. So if you're fixing a fracture, or if you're fixing a cataract, or you're taking care of a hydrocele, you're not necessarily prolonging that person's life per se, but you are dramatically improving that person's quality of life by performing that operation. And the third thing we know is that surgery costs a lot of money. So how do we measure this sort of cost-benefit ratio? How do we determine surgery saving lives and surgery improving lives, but also surgery costing money? How do we put that all together to come up with a cost-benefit analysis? So let's go to the next slide here. To do that, the WHO actually has a specific methodology. It's called the WHO Choice Program, choosing interventions that are cost-effective. If you're going to get into cost-effective analyses, the WHO Choice methodology is a great way to do it. Most of the literature that's out there that we will be reviewing a little bit later in the presentation uses a mixture of stuff. So they don't necessarily use the WHO Choice. but it is a very standardized way of doing it, and we're going to be sort of discussing the way they talk about that. Let's go on to the next slide here. So to do a cost-effective analysis, we really have to do two things, right? We have to measure the cost of the surgery, and we have to measure the level of improvement that the surgery brings. Cost of surgery is, relatively speaking, the easier thing to do, right? We can just figure out how much it costs to pay the personnel, how many supplies we use, how many medications we use, and we just figure out how much all that stuff costs. We can figure out in local currency. The WHO choice methodology has us use US dollars in 2012. If you're an international health economist, you can use international dollars, which takes into account the triple P of the country. That's sort of the easier thing to do. The harder thing to do is trying to measure the level of improvement that surgery brings, because surgery can do one of two things. It can either save a life, that is, can reduce mortality, or it can improve the life, that is, reduce morbidity. So it's one or two of those things. We have to figure out how we can measure that level of improvement if it's doing one or the other, or even both. So next slide. So to do that, we have something called the DALY. The DALY stands for Disease-Adjusted Life Year. And what this does is it measures the burden of a disease. That is, it combines a disease's morbidity and mortality, and it basically translates that into one number. What the DALY allows us to do is it allows us to compare all sorts of diseases to all other sorts of diseases. So here it doesn't matter whether you have a medical disease or an obstetric disease or a surgical disease. If you can translate it into DALYs, you can compare apples to apples. You can compare a disease's morbidity and mortality from one type of or one kind of disease to another kind. So next slide. So, here we go. There we go. So a DALY, here's some of the math. A DALY is equal to YLL plus YLD. YLL is the mortality, that is the years of life lost. This is a relatively easy thing to think about. So on. Okay. If you have a life expectancy of, say, about 80 years, and then you have some sort of disease that reduces your life expectancy to 60 years, you lost 20 years of your life to that disease. So that's your YLL. That's 20 years straight up into the equation, fairly easy. The YLD is loss due to disability, and this is our calculation for morbidity. This is a little bit more of a complicated equation, because you can imagine there are some diseases that are very disabling but last only a short time. There are some other diseases that are not that disabling, but they can last for a long time. So to calculate the YLD portion of this equation, we have to be able to factor in not only the severity of the disease, but the expected length of the disease. And so that's where the complication, the equation gets a little bit more complicated. So to calculate the YLD, we use disability weights. And so basically this is some decimal number that's assigned to a lot, not all, but a lot of diseases around the world to quantify the consequences of non-fatal disease and injury. It's basically a decimal or fraction between 0 and 1. 0 means you have no disability, 1 being completely disabled, or in other words, dead. So you could have something that's very not disabling, like a simple URI would be about 0.005. You can have something that's very, very disabling. An acute bout of schizophrenia that goes untreated is ranked about disability weights. Anywhere along between 0 and 1, depending on what sort of disease you have, it'll be assigned this disease weight, and that's what goes into that morbidity portion of the calculation for our DALY. Let's go on to the next slide here. So again, DALYs allow us to compare disease burden and interventions to reduce that disease burden, and we'll talk about that in a minute. Just a quick note for those of you who are interested or familiar with this, DALY is a measure of disease burden, meaning that if you have a lot of disease burden, you're going to get a high DALY number. So what we're looking for here is actually a low number. We want a low number. We want to have a smaller burden of disease. So when we look at DALYs, what we're aiming for is a low DALY number. For those of you that do research, you may be familiar with the QALY, or the Quality Adjusted Life Year. This quantifies health. So in that case, we are looking for a bigger number. We want more health in general. Why do we use the DALY versus the QALY? Mostly because, again, the WHO's preferred method for cost-effective analyses in global disease burden problems is to use the DALY. So that's what we're going with here. And next slide. Okay. So any sort of treatment, any sort of medical intervention, whether it's surgery or whether it's medication, malaria medication, or whether it's doing a vaginal delivery, or whether it's handing out bed nets, any sort of treatment, what are we trying to do? We're trying to reduce the global burden of disease, right? In some fashion, we are trying to reduce either the morbidity or the mortality of a particular disease. So another way to say that in terms of DALYs is that treatments aim to avert DALYs. That is, we are trying to decrease DALYs. So you have some disease, you have so many DALYs to begin with, then you receive a treatment of some sort, and your DALYs decrease as a result of that treatment. That is, your burden of disease goes down as a result of that treatment. So treatments aim to avert DALYs, and that's the terminology that we're using here. Let's go on to the next slide. Okay, so let's talk about this. We can put this all together. If we know the cost of particular treatment, and if we know the number of DALYs that that treatment averts, so we know how much disease burden goes down as a result of that treatment, then we can calculate the cost per DALY averted. And to do this, it's just a simple fraction. You literally have the cost of the treatment on the numerator, and you have the number of DALYs that are averted on the denominator, and then you just reduce the fraction. So what you're going to end up with is you're going to end up with some dollar amount or some currency amount over one DALY averted. Again, what we're looking for here is lower costs, lower numbers, right? So the lower cost per DALY averted means that you are, for every dollar you put in, you are getting more burden of disease is being reduced. You are getting a bigger bang for your buck. So again, we're looking for the lower cost per DALY averted. That means from a public health standpoint, we are getting the biggest bang for our buck. So that's how we sort of do these cost-effective analyses for different types of treatment by doing this cost per DALY averted analysis. Next slide. Okay, so we've taken our little detour now through public health math, and hopefully that wasn't too depressing. We're going to look now a little bit at the literature, and this is a very brief literature review at cost-effective analyses. So let's go on to the first slide there. If you're a surgeon, a CEA stands for carotid endarterectomy. If you're medical, it's probably a carcinoembryonic antigen. But if you're in public health, the CEA is a cost-effective analysis. And so this was one of the first CEAs to come out in the literature. This was 2003. We're looking at a small Bangladeshi hospital. It's about a third medical, a third surgical, a third OBGYN, and there's actually about 10% pediatrics in there, so fit that in somewhere. What they did was very simple. They just took a 3-month period and they calculated the entire cost, the cost that would run that entire hospital for those 3 months. So they looked into everything from the depreciation of the buildings to the cost of all the personnel to all the consumable goods used. And they just took that entire number, all those costs, and just gave one big number. This is how much it costs for those 3 months. Then they did a DALY analysis for the same 3-month period. They looked at all the patients, and they looked at all the DALYs that were averted as a result of the treatment that the hospital provided, both inpatient, outpatient, but mostly inpatient, actually, looking at medical, surgical, OBGYN, and pediatrics. And they just looked at every single patient, all the disease they had, and how much their disease burden was relieved or averted by being in that hospital over the same 3-month period. They took the cost, they put it in the numerator, they took that total number of DALYs, they put that in the denominator, and that was a fraction they came up with. So $10.83 US dollars per DALY averted. So just keep that figure in your mind for a half second. About $10 per DALY averted is what it costs in this Bangladeshi hospital. So let's go on to the next slide. In 2006, the World Journal of Surgery did a very similar analysis, again for 3 months at an Italian surgical hospital in Sierra Leone. The difference here is that this is a non-obstetric hospital, so they don't do C-sections or tubal ligations, that sort of thing. Same process, all costs over 3 months divided by the all DALYs averted over the same 3 months. And their number they came up was $32.78 per DALY averted. So a little bit higher, most likely because obstetrics tends to be a fairly good bang for the buck operation. That is, you're not only typically saving just one life, you're saving two, so you get a lot of DALYs averted, so you really get a lot of reduction in disease, mortality, and morbidity for the amount of money you put in. 10 years later, World Journal of Surgery does the same sort of analysis here. They're looking at a much bigger hospital in Zambia, but this time they're not looking at the medical or pediatric side. They're looking only specifically at surgery and obstetrics. Again, does the same sort of analysis, looking at all the DALYs averted in the surgery and obstetric wards, looking at the costs for those patients, and they come up with $10.70 per DALY averted. We're actually getting to the point now where we've done so many of these studies that we can do systemic reviews of the literature, looking at these cost-effective analyses around the world. So in 2014, again, World Journal of Surgery did a systemic review, and here they're looking at the cost-effectiveness ratios. Again, we're looking at US dollars per DALY averted. And so they give here a range for different types of operations. So cleft lip and palate repair, something that I've done in my practice, that's somewhere between 15 to 96 US dollars per DALY averted. Hernia repair, roughly the same magnitude. We're looking at $12 to $78. Short-term orthopedic missions, these tend to be the most expensive in terms of cost-effectiveness ratios. So we're looking in the $300 range or so. If you're looking at a whole hospital, similar to the previous studies we just looked at, you're just looking how much does it cost for this whole hospital to run if it has surgical capabilities. Again, we're looking at somewhere between the $30 to the $200, $230 range. The higher range of that typically is hospitals with trauma capabilities. So these are all sort of just ranges, again, using these units of dollars per DALY averted. In the next slide, we'll see another systemic review. This was a year later, 2015 Lancet Global Health. This was one of those many supporting studies given with the Global Surgery 2030 report. Here, they just gave the median cost-effectiveness ratios. Same units again, US dollars per DALY averted. These are in 2012 US dollars. And they just give a single number, the median. So male circumcision turns out very good bang for your buck there, only $13 per DALY averted. Cleft lip and palate, again, about $50. General surgery performed in a hospital, so laparotomies, hernia repairs, that sort of thing, we're looking at about $82 per DALY averted. Hydrocephalus, a little bit more, about $100. C-sections, about $300. And again, orthopedic surgery, fairly expensive. Here in their analysis, they have it about $380 per DALY averted. So we've got all these numbers, right? And we, generally speaking, have about $10 to $400 per DALY averted is the numbers that we've looked at, both in single journal articles as well as in the systemic reviews. And that's very nice to know and all, but here's the real crux of the argument, and here's how we can make that case for global surgery. We have to know what is the cost per DALY averted for all the other public health measures that are out there. So for the classic things that we think about as public health, whether it's immunizations or breastfeeding or HIV medications, what is their cost per DALY averted, and are they at all comparable to surgery? So let's go ahead and look at it on this first slide here. Again, going back to HIV, TB, and malaria, you know, that's what the Global Fund supports. So let's look at those ratios. Again, these are in 2012 US dollars per DALY averted. And antiretroviral treatment for HIV, about $400 to $600 per DALY averted. Looking at TB, if you are a child in a TB endemic area, you probably got a BCG vaccine. That's somewhere between $50 to $200 per DALY averted. If you're receiving direct observed therapy for treatment of active tuberculosis, again, we're looking about $5 to $40. Malaria treatment, just handing out bed nets for people to use and educating them about how to use it. That's about $6 to $22 per DALY averted. And for malaria treatment, this is a single course of malaria treatment using artemisinin for acute bouts of malaria. We're looking about $100 to $150 per dali averted. Let's look at the next slide here. Here are some other things that you might think of in terms of public health. Vitamin A supplementation to prevent night blindness, about $10 per dali averted. Trivalent or actually even pentavalent vaccines. Vaccines is a big public health outreach, right? That's about $13 to $26 per dali averted. Oral rehydration solution for diarrhea. Diarrhea, of course, being one of the leading causes of mortality for those children under the age of 5. Again, we're looking at the low end $150 and at the high end even thousands of dollars per dali averted. And for the medical treatment of ischemic heart disease, which is still a cause of mortality both in the developed and the developing world. And we're not talking about fancy stuff here. We're talking about an aspirin and beta blocker. The cost for that is $500 to $700 per dali averted. So I think you can see here, looking at the numbers for the traditionally thought of medical interventions for public health, we're looking at the same sort of ratios or the same sort of dollar amounts that we had for surgery. At the low end, somewhere around $10 per dali averted. At the high end, several $100s per dali averted. But really, in terms of the cost effectiveness ratios, the numbers are very similar in terms of reducing that burden of disease. It costs about the same whether you're giving TB medication or malaria medication or HIV medication, or if you're fixing a hernia or a cleft lip or doing a C-section. So on to the next slide. And here we have our summary. Hopefully, I've sort of shown to you how surgery has a similar cost effectiveness to other public health interventions. Because surgery and anesthesia still plays a large role in death and disability. Again, that 6.5% number for averted, possible averted deaths is at the low end, but it still plays an important role. And so as a result, surgery really is increasingly playing an important role in the global health movement. Cost-effective analyses are playing a big part into that, showing how it can actually be cost-effective to do surgery in the developing world to reduce that burden of disease in the same way that we do with HIV, malaria, tetanus, immunizations, and that sort of thing. That's the end of the presentation on that.
Well, thank you so much, Dr. Huang. I want to remind our viewers that if they have questions or comments, they can post them on the group chat in the side. Just excellent presentation, I think. I learned a lot for sure, and I hope you did too. As we wait here for your questions, I just want to remind you that CME credit is available for this session, and the form and instructions are in your email, and we'll send out a follow-up email with the links to the recording. If you're not on our email list, you can also join this forum at health.samaritans.org, and you can be the first to know about these upcoming events as well. Yeah, I think it's just fascinating presentation to think about. I think what you said earlier, Dr. Huang, with 5 billion people lacking safe, affordable surgical and anesthetic care, just seems like a big number.
It is a huge number, absolutely. Yeah. I mean, if you think about 5 billion, we're literally talking about the majority of the world there. So that includes people in America, and specifically because they define there in the 2030 report as being both safe and affordable meaning that you don't go into basically personal bankruptcy or you don't lose all your financial resources. And quite frankly, in America, we have happens, right? Medical costs are one of the leading causes of personal bankruptcy in the United States. So as a result, we could define some proportion of the American population as not having access to safe and affordable care if they can't afford it or if they don't have the appropriate insurance. Most of the cost-effective analyses obviously are done in the more developing world. So there we're looking at sub-Saharan Africa, we're looking at Central and South America, or we're looking in South Asia. And so that's where you're going to find the majority of that 2 billion people that don't have access to even basic surgical care.
Yeah, it's just a large number to think about. And I've thought in Africa and other places as well, when you look at how many surgeons there actually are available, even if you could pay for the surgery, it just doesn't seem like there's many surgeons available either to actually do the surgery, and that's a problem as well.
Absolutely, yeah.
I'm sure you've seen that. We do have Marvin Hodge wants to ask you, describe how you have seen missionary medicine and the impact of surgery in the developing world. Can you speak to that just a little bit?
Yeah, so I should preface that by saying most of my experience in the developing world is, I would say the majority of it is now surgical. A lot of it is actually through the hospitals that World Medical Mission supports. And so I specifically, as a surgeon, have tried to go to places that have surgical capabilities. The operations, for those of you who are familiar with it, it's a very familiar scene no matter where you are in the world. The theaters are always small and poorly lit, and you're always reusing a lot of things that you wouldn't reuse in America or in Canada or in Western Europe. Tapes or gloves yeah, respiratory tubing, that sort of thing. But it's obviously very personally satisfying to be a surgeon in those circumstances, because you can do a lot of good for certain categories of patients. It can also be very personally frustrating because so much of the surgical burden of disease goes untreated for so long. By the time that they come to the institutions I've been at, a lot of them are simply too far gone. They have diseases that cannot be treated surgically or cannot be adequately treated in surgery. So you do have certain operations that you can do, and a lot of those are mentioned in that list of essential surgery, that are satisfying to do because they are something that can immediately reduce mortality or morbidity. You can fix a hernia and do a good job with that. You can fix a typhoid perforation and do a good job with that. But there's a lot of things that come in that we wish we could have seen a lot earlier, right? So a lot of very advanced cancers, or perforations that have gone too long and now they're septic and they simply die too quickly, or burns that go untreated and end up with very severe burn contractures. So there's definitely this mix mash of things, both things that can be satisfying to perform and things that can't be, or are not satisfying because it's just simply too much for the surgeon to handle. And I think that's a lot of this emphasis on essential surgery. If we can train more people to perform a core group of about 20 different operations, and we have more people that are able to do those operations, then the surgical burden of disease goes down globally by quite a lot. The most controversial aspect of that essential surgery is whether or not non-physicians should be allowed to do these essential surgery things. So should we be training non-surgeons or non-physicians even to be doing things like fixating fractures or hydrocelectomies or C-sections? And so that's one area of controversy going out in the world right now.
Sure, that's great. Linda McBride has a question as well, and she asks you, she's a little confused on the daily averted ratio. For cost effectiveness, do you want a higher or lower daily ratio? Right.
So the way the ratio is built, because you have the costs on top and the DALYs on the bottom from the numerator and the denominator, you're looking for a lower number. So the lower cost per DALY averted means you're getting more bang for your buck. So as an example, for TB, if you do direct observed therapy, right, DOT treatment, you have somebody physically handing out the anti-TB medications. That is a relatively low cost per DALY averted, $5 to $40. That means you can have one person handing out medications and many people. The medications are quite effective. They reduce a lot of the mortality and the morbidity, and so that's a very cost-effective thing. HIV medication, on the other hand, has a much higher cost per DALY averted, so in that sense, you don't get quite as much bang for your buck. And the reason for that has to do with cost of HIV medications, as well as the difficulty in getting it to people. And some of the other issues with getting antiretrovirals to the people that need them most.
That's great. I just have a question too. We've talked about you've made a great case for global surgery and just with the lower daily ratio, DALY ratio. Speaking of it from a Christian perspective too, can you advocate maybe even just from a Christian perspective why global surgery is important?
I think as Christians, we are called to treat the widow and the orphan, and if and the immigrants, right, the foreigners in our land. And it's very obvious that Jesus has during his ministry, he had a huge heart for the poor, for the people that were rejected and dejected as a result of their poverty. So as Christians, if we want to follow in Jesus' footsteps, we want to treat the poor, and we want to treat them. We want to treat them globally, right? We want to present the gospel, and we want to treat their physical needs as well, because we are both body and spirit. We were created that way, and we will one day be resurrected that way as body and spirit. So that's sort of the general reason for medical missions as part of Christian outreach. And I think these analyses that are coming out just in the last few years sort of help promote the case for surgery as part of that medical mission outreach. There are increasing numbers of Christian surgeons that are interested, even in my personal circle of friends, interested in medical missions. It's something that surgeons want to get involved with, but previously had thought it's kind of difficult to do it because of all the baggage that's required, because of everything you need. It's not like other public health outreaches. But the case is being made that it should be, and that getting the infrastructure in place, although it's more difficult, does provide long-term benefits for a community. And it also allows for a community to flourish, because now you've got sort of a more stable medical infrastructure. If you're offering surgical capabilities, it means you've developed something. You've developed something enough to be able to create that infrastructure, and that means a lot to the people that you're going to be serving.
Mm-hmm. Well, that's great. Well, thank you so much for joining us today. Like I said, it was a great presentation, and I'm sure our viewers learned a lot. And we just appreciate you taking time to share with us. For the rest of you, we just thank you for joining us today. And our next forum will be on November 9th, and it is with Dr. Alan Sawyer. We hope you can join us. He'll be speaking about the management of primary postpartum hemorrhage. And so I'm sure that will be a great topic and a great forum as well. So please join in us next November 9th. We'll be sending you out some reminders on that as well. Thanks again. Have a great day.